So malignant spinal cord compression is a potentially devastating injury to the spinal cord. It can lead to progressive and permanent motor and sensory deficits if left untreated. I suppose my takeaway message for what nurses need to educate patients about is, I've mentioned pain, muscle weakness, change in sensory perception. But as always, anything new, anything different, anything that feels a little bit troublesome should be reported. We'd much rather have it turn out to be nothing than have it turn out to be something serious.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today, we're talking with ONS member Jennifer Webster, Clinical Nurse Specialist at Georgia Cancer Specialist, affiliated with Northside Hospital in Atlanta, Georgia, and member of the Metro Atlanta ONS Chapter, about the latest nursing management and prevention strategies for malignant spinal cord compression. This episode is part of a series about oncologic emergencies. The previous episodes are linked in the episode notes. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, Jennifer.
Thank you. I was so honored to be asked to speak today, and I'm very excited to be talking about this topic.
This is definitely one of the areas that we enjoy doing podcasts on, because oncologic emergencies are things that every oncology nurse is going to experience at some time in their career. And with a lot of new to oncology or new grads coming into the oncology arena, it's such a great topic for them to understand and to learn from some of our experts on. So to start us off, can you give us some background on malignant spinal cord compression? Tell us what it is and how does it present?
So malignant spinal cord compression is a potentially devastating injury to the spinal cord. It can lead to progressive and permanent motor and sensory deficits if left untreated. I do want to mention that spinal cord compression can occur in other situations. Think about motor vehicle accidents or other traumatic injuries. You've heard of people having paralysis depending on their spinal cord injury. So malignant spinal cord compression occurs in the setting of cancer, primary or metastatic cancer. Therefore, that's why we carve it out as malignant spinal cord compression rather than just spinal cord compression. What happens is that the tumor or the metastases spread to the vertebrae, and that results in collapse of those vertebrae onto the spinal cord. Or less commonly, there is a direct metastatic spread into the epidural space or cord. The Oncology Nursing Society has identified malignant spinal cord compression as a structural oncologic emergency. We know that it occurs frequently late in the course of disease, but it can happen at any time. It can often also be the initial manifestation of malignancy.
That's really good to know. And I think that, as you pointed out, there are other non-cancer related ways that folks can have spinal cord compressions. It's really important to understand how this happens and manifests in a patient with cancer, because you may not think of that with someone that has a diagnosis of lung cancer or breast cancer and why that would happen with them. What are some of the early and late signs of malignant spinal cord compression that a nurse might recognize with a patient?
The most commonly occurring complaint of patients who have developed malignant spinal cord compression is that of pain. We see it in 95% of patients who present with malignant spinal cord compression, which at times, by the way, you're going to hear me say MSCC just because it's a little bit quicker. So about 95% of patients experience back pain. It can be very acute if there's a sudden collapse of the vertebrae onto the spinal cord. But more frequently, what we see is that it starts out as a dull, aching, constant pain that progresses in intensity over time. And so because of that, it can be very difficult to identify it as a serious problem initially. I mean, think about us. How many of us have experienced back pain at some time or another? And the problem is that we have a tendency to self-treat, right? Oh, I pulled my back lifting something heavy or something similar to that. We treat with heat, we may use ibuprofen, etc. And so often what happens is that patients as well have difficulty identifying this back pain as something that could be potentially serious and that they should seek medical care for it. I have a great example of this of a patient who had breast cancer, was in remission, and regularly did gardening work, and one day felt sort of a lower ache in her back and just assumed that it was related to overdone it, as she said, doing the gardening, weeding and planting, and self-treated for several days. The pain continued to get worse and worse. And finally, it became almost excruciating. And that's when she sought medical help. So it's very difficult for patients and potentially for nurses to have this back pain sort of top of mind as something that they should be exploring further as quickly as possible. I did want to mention something else about the pain. I talked about it being aching and low and dull and then progressing. There are patients who do experience a burning or shooting pain, and that could potentially extend to a particular limb or an area of the body following a nerve path. Keep in mind that all these signs and symptoms are related to where along the spinal cord the pressure of the tumor or the vertebral collapse is happening. And so, although I am describing the most general manifestations, there can be very particular acute manifestations that are dependent on where along the nerve path is being affected by the spinal cord compression. The other piece of the pain is that what we often see is as it increases in intensity over time, also certain activities may make it worse. So anything that contributes to straining, such as lifting a heavy object, coughing, or sneezing, may make the pain worse. There may be patients who find that lying in certain positions makes the pain worse. So it is not a commonality that it's all just an ache that eventually gets progressively worse. The second most common manifestation, which is seen in about 60 to 80% of patients, so still a very large number of patients at diagnosis of malignant spinal cord compression, is motor weakness. Again, it could follow the course of a particular nerve. If there's a particular nerve involved, they may have motor weakness just in a particular limb, but most typically it manifests as a bilateral weakness in the legs. Again, it can be very subtle. Patients will describe having foot drop, being unable to pick up their feet correctly, or they may describe a heaviness in their limbs or stiffness. And the first way they notice it is that they start having difficulty getting out of a chair or maybe climbing some steps that used to be easy to do. And then it becomes increasingly difficult to ambulate, even on flat surfaces. In fact, the ability to walk upon diagnosis is actually a significant association with full return to mobility. So in other words, if patients have reached a point where they're unable to walk when they are finally diagnosed with malignant spinal cord compression, then it is a much higher likelihood that they will never be able to return to full mobility. Along with motor weakness, we may see sexual dysfunction, such as impotence in men. And then along with that, we may also see sensory loss. which occurs in about 50% of patients, again, depending on location, but it often starts as numbness or tingling in the lower extremities and can progress to loss of sense of touch or pain and heat. I'll never forget a young man that I took care of who had a lymphoma. This is many years ago, who had a lymphoma and was in our facility for treatment and was receiving chemotherapy, and was a very ambulatory young man walking around chatting to people, and called one day for assistance to the restroom. The nurse who went in to help him knew that he was very independent. And so she asked him, why is it that you need assistance? I'm surprised that you need assistance. And he said to her, well, just in the last couple of hours, I got this numbness and tingling in my feet, and I'm starting to have trouble walking. So this was a nurse who immediately recognized that this could be a very serious problem and immediately contacted the physician to notify them about these problems that the patient was exhibiting. By the time they were able to get him in for treatment, he had completely lost sensation in his lower limbs. Just within a few hours, this was how rapidly this was happening. And after intervention, he was able to maintain mobility or return to mobility, but he always had a little bit of difficulty walking and did require using a cane. However, if the nurse had not discovered it as quickly as she did, or assessed it and evaluated it as quickly as she did, then the patient could have had permanent loss of lower motor function. The other thing I want to mention is that, again, I've talked about the numbness and tingling usually in the legs, but they can occur in the hands or other parts of the body. I think this can be particularly difficult to identify in patients who have received treatment that we also associate with peripheral neuropathy. So, for example, the taxanes or vinca alkaloids may patients to already be experiencing these side effects, or they've already been educated about these side effects and that they may happen. So again, there is a tendency to perhaps not ignore these signs and symptoms, but to not necessarily associate them with a more serious outcome, such as malignant spinal cord compression. And then finally, I do want to mention that there is a late sign of malignant spinal cord compression, and that is autonomic dysfunction. Usually it starts with bladder dysfunction. About 50% of patients who are diagnosed with malignant spinal cord compression have bladder dysfunction. It can start with difficulty voiding, urinary hesitancy. Eventually, it can lead to urinary retention, and then patients can be incontinent as well. As far as bowel function, patient may have difficulty bearing down, difficulty expelling stool, and then this progresses to constipation and fecal incontinence. And I've already mentioned as well, inability for men to have an erection can be a sign of autonomic dysfunction. Autonomic dysfunction is a late sign. At that point, the malignant spinal cord compression is quite serious. Very often patients are already unable to ambulate or having difficulty ambulating and are having severe pain. And so again, it's an indication that we may be able to treat the malignant spinal cord compression and assist patients in returning to a more normal mobility and hopefully comfort level. But we are probably at this point dealing with a malignant complication that we are not going to be able to resolve completely. And also recognizing that it's a very poor prognostic indicator for the cancer overall. In other words, at this point, patients are rarely, in fact, never going to be cured of their disease. When we're seeing late signs of this complication, then that is a sign that we do not have this disease under control. And most likely, this patient's lifespan is fairly short.
Well, Jennifer, as you've gone over the manifestations and those early and late signs, the examples you gave were wonderful. And with so many patients being treated outpatient, as you mentioned, they might have some of these signs and symptoms and they decide that, oh, I slept wrong last night, or like you said, I bent down and I tweaked my back. But how important it is for us as nurses to really understand and be in tune with what those signs and symptoms are and what patients may be at risk, because you are going to have to act very quickly. Like you mentioned with one nurse and the young patient with the numbness and tingling in his feet. So if we're talking about spinal cord compression, there's also cord impingement. What is that and why does that matter? Is that different from spinal cord compression?
It's a part of spinal cord compression. So the idea is that you are putting direct pressure on the spinal cord. And of course, depending on where that direct pressure is happening and how significant that direct pressure is, that is going to manifest itself in the signs and symptoms that the patient is experiencing. And of course, you've touched on the whole issue of that these signs and symptoms often are somewhat vague for patients, and especially if they're occurring slowly. We all have that self-talk of, oh, it will be better tomorrow if I do X, Y, and Z. And what we as nurses need to do when educating patients is to make sure they realize that we don't want that self-talk in this situation, that we want anything that feels a little bit different, worries them a little bit, is something that we need to know about. We call spinal cord compression or malignant spinal cord compression a medical emergency or oncologic emergency for a reason. Even though it's usually not life-threatening, I suppose it can be if the lesion or the spinal cord impingement is in a place where, for instance, respiratory function is compromised. But for the most part, it's not life-threatening. However, we call it an emergency because the longer we wait, the worse the side effects are going to be, and the more debilitating and devastating these side effects will be for patients. And we're talking about patients who, for the most part, are at the last few months, potentially a year or two of their lives. And so we really want to maximize their quality of life and reduce any of these sensory problems and, of course, pain as quickly as possible to try and maximize their quality of life. In other words, if we can intervene quickly, I mentioned this young man, if we hadn't intervened quickly with this young man, he could have been potentially paralyzed from the waist down, incontinent, had bowel problems. That's not a great way to spend the last few months to a year or two of your life if we can prevent it from happening. So we call it an emergency because of these devastating effects of the malignant spinal cord compression. However, in most cases, it's not life-threatening. It really does depend, though, of course, on where the spinal cord impingement is happening and how much pressure is being put on the spinal cord.
Now that we've talked about what those signs and symptoms are, can you talk to us about what populations may be at risk for developing a malignant spinal cord compression?
I love this question because I think it helps oncology nurses think about cancers as a whole and how they may impact different parts of the body. So for malignant spinal cord compression, I want oncology nurses to think about solid tumors that are commonly located near the spine and that also metastasize easily. Those are the ones that put patients at greatest risk. So think about lung cancer, breast cancer, prostate cancer, renal cell cancer. All of those are near the spinal cord, and all of those have the potential to metastasize. And in fact, those four that I mentioned, lung, breast, prostate, and renal cell, make up over 50% of all cases of malignant spinal cord compression. However, I also want oncology nurses to think about the hematologic malignancies because they also can pose a significant risk, particularly multiple myeloma. One of the hallmarks of myeloma, as you know, is the clustering of plasma cells in the bones, and they weaken the bones. Well, the vertebrae are not immune to this clustering of the plasma cells. And so if you can think about that, having clusters of plasma cells that are in your vertebrae, then naturally it makes sense that those could eventually collapse onto the spinal cord. It's estimated about 10 to 15% of all multiple myeloma patients may experience MSCC. So again, this is another group that nurses who work with those populations need to keep in mind. Also, non-Hodgkin's lymphoma and Hodgkin's disease, they don't necessarily weaken the bone, but tumors may exist or be growing in nearby lymph nodes or actually invade the spinal cord. They make up about 5 to 10% of the malignant spinal cord compression cases that we see. So the vast majority are the solid tumors I mentioned, lung, breast, prostate, and renal cell. Then multiple myeloma patients are also at risk. And on top of that, non-Hodgkin's and Hodgkin's disease patients. And finally, unfortunately, the other group that's at risk is really anyone that has metastases. Although we know that there are general patterns of metastatic spread, once a tumor has metastasized wherever it is, then of course there is the chance that it could metastasize either to the vertebrae or to the spinal cord itself. And so we need to be aware of this amorphous population of anyone with metastases that could potentially develop malignant spinal cord compression.
That's excellent. I think it's really important that nurses understand what patient populations and thinking about who they work with, that they could be at risk. So if a nurse does have someone in one of these patient populations as a patient that they're working with, what should they teach the patient and then caregivers about malignant spinal cord compression and what they need to watch for to recognize this emergency early?
I've sort of already alluded to it as far as what we see as the manifestations. Any unusual pain, or even usual pain, I should say. And, again, like I mentioned, with back pain, we all occasionally have back pain, but any new pain, but particularly pain in the back, we don't want patients to wait until it's severe. So even just a little bit of throbbing or aching is something that needs to be reported. Pain of any type that is new. And I think, of course, we say that in general for all oncology patients. We don't want our patients to be experiencing pain that we don't know about, whether it's related to malignant spinal cord compression or not. So any onset of pain, any onset of new muscle weakness. I could walk up the stairs yesterday, and today I'm really having to think about lifting my legs, and I feel so tired and my legs feel so heavy after walking up these few steps to the front of my house. Anything that's unusual like that or that's new. We don't want patients to brush it off as fatigue, that, I'm just tired today. Any difficulty or change in the way they're moving, getting out of a chair. I need to lean a little bit on my kitchen counter as I'm walking. I feel a little stiff as I'm walking. Anything like that needs to be reported. Along with that, any change in sensation. I notice that I'm walking on my cold tile floor and it doesn't feel cold to me today. Or, as I mentioned, this young man noticing that he couldn't pick up his feet quite correctly. Anything new. I can't tell when I dip my toe into the bathtub that it's warm, or I'm using a hot pack somewhere and I'm not really feeling the heat. Any sensational change like that, of course, we'd like to know about. Hopefully, if those things have just started, then we can consider those fairly early signs. And if we can intervene quickly, then they may not have any further problems, or we may even be able to reduce those problems that they are reporting to us. Once patients start to experience urinary incontinence, difficulty urinating, Men notice that they can't have an erection, which again, often is put off as sort of like fatigue. So if they notice that they can't have an erection, or the patients start having constipation and they've never had problems before, all of those can be autonomic dysfunction. And those are late signs. But of course, we still want to know about those as soon as patients have them, again, trying to intervene as quickly as possible. I suppose my takeaway message for what nurses need to educate patients about is, I've mentioned pain, muscle weakness, change in sensory perception. But as always, anything new, anything different, anything that feels a little bit troublesome should be reported. We'd much rather have it turn out to be nothing than have it turn out to be something serious that was just, self-medicated or self-treated because patients didn't think it was serious enough to bother the healthcare team, which of course we hear about all the time.
Thank you. I think it's important to make sure that our patients understand that you really are not bothering us when you call. We really want to know what's going on and how you're feeling.
Absolutely. I always say, and I say this about reporting any symptoms, I use the analogy of, if you wake up in the morning and you have a little bit of a headache, if you took some Tylenol right then, you would feel better, but you don't and you ignore it. It gets worse and worse and worse. And by the end of the day, regular Tylenol just isn't going to help. Well, I want patients to think about their symptoms like that. If they wake up in the morning and they have a little bit of pain, we can do something about that right away, and we can potentially stop it from getting worse. The longer they wait, then the harder it becomes to treat, whether it's pain, motor weakness, sensory loss, etc. It doesn't matter what it is. The longer they wait, the harder it is for us to treat.
Exactly. We've talked about the signs and symptoms and the patients that may be affected. Let's talk about how this is diagnosed for a patient who is complaining of pain and reaches out, and we are suspecting that it might be a malignant spinal cord compression. What does that look like as far as the diagnosis goes?
Besides a history and physical, usually if we're suspecting spinal cord compression, we're also doing a comprehensive neurologic exam. If the physician suspects malignant spinal cord compression, then they may order spinal x-rays. Those can usually be very helpful in identifying vertebral body collapse. In fact, about 70% of malignant spinal cord compressions can be detected with spinal x-rays. There may be suspicion of tumor in the spinal canal, and so patients may have cerebrospinal fluid inspected via a lumbar puncture. Also to rule out the possibility of infection, because that could potentially be causing some of these signs and symptoms. However, the gold standard to confirm malignant spinal cord compression is an MRI with contrast. It is the test of choice because its overall diagnostic accuracy is 95%. You would like it to be done within 3 to 6 hours of onset of any of these signs and symptoms that you're suspicious of. That can be difficult if this is outside of normal business hours and MRI facilities near you are closed. Or the other piece of the difficulty with MRI is that patients, of course, have to lie still. And if they're in bad pain, or if the position that you have to put them in is increasing the pain, they may not be able to do that. So in those cases, then CT with contrast and a myelogram will be ordered. But if we have the option, we would really like to have an MRI with contrast done quickly.
Then what would be the interventions once the diagnosis has been made?
Interestingly enough, there's one intervention that is used even sometimes before the diagnosis has been made if there is suspicion of malignant spinal cord compression, and that is the use of corticosteroids. What the care team is trying to do is decrease the inflammation. So they will often administer corticosteroids before they even have any of the complete diagnostic results available. simply because, again, the sooner that they can reduce pressure on the spinal cord, the more likely they are to have a positive outcome for the patient. Once the patient has been diagnosed, then again, steroids will be used. The next, and again, it depends on what is causing the cord compression, but most likely the patient will receive external beam radiation therapy directly to the tumor that is pressing on the spinal cord or the metastases that is impinging on the spinal cord. Surgery will be used in very specific cases. It's a little bit controversial. It's becoming less controversial as we have more non-invasive or less invasive ways of stabilizing the spine. The surgical decompression and the ability to stabilize the spine have been the hallmark of why we would use surgery. But when you think about traditional spinal surgery, it's very invasive. It takes a long time for patients to recover. So there has been an attempt to limit that to patients who have more than 3 months to live, or it's predicted they have more than 3 months to live, because of the other potential serious outcomes from spinal surgery. Having said that, now that the surgical techniques and options have improved, we have vertebroplasty and kyphoplasty, which is the patients have a very localized insertion of a catheter at the vertebrae that is collapsing. And then a balloon may be inserted that helps to expand the vertebrae, and then a sort of cement-like substance may be inserted into that. And because of that option, and it's a more positive outcome for patients and can be done fairly quickly, surgery is now becoming more of an option, or this particular type of surgery is becoming more of an option for more patients. I keep mentioning tumor. And so, of course, as oncology nurses, you're also thinking about chemotherapy. We do use chemotherapy in certain situations, but it's rarely used initially. Remember, of course, we're trying to intervene quickly. Radiation therapy usually works fairly quickly. We know that obviously surgery can work very quickly. And chemotherapy is more of a systemic treatment. It can be a little bit more unpredictable. So it's rarely used initially. But once we've gotten the patient stabilized, then chemotherapy may be used in an effort to try and shrink the tumor that is impinging on the cord or the metastases that are impinging on the cord. The other treatment that these patients may already have been on, but also may have started once we determine that they have malignant spinal cord compression, is the use of bisphosphonates or denosumab. These are bone modifying agents that are used to help strengthen the bone and stop their breakdown. And so you actually may have patients who are already on these agents as a prevention of malignant spinal cord compression, particularly obviously the vertebral collapse. But if not, then they may be started on these as a way to try and prevent further collapse or collapse in different areas of the spine as well.
So, Jennifer, what would be some of the most important nursing considerations for patients with a malignant spinal cord compression?
Malignant spinal cord compression really uses all of an oncology nurse's skills. First of all, they have to do an ongoing assessment of pain, neurologic deficits, and sensory deficits. They need to be aware of pain management interventions, and that's going to be a very high priority for these patients. Remember, for many of these patients, they are now at the end or getting close to the end of life. So many of the nursing interventions are going to be related to palliation of symptoms and supportive care, which obviously includes pain management, safety issues. If patients have mobility or weakness issues, they may need physical support. Nursing may need to be involved in helping physical therapy, assist the patient, occupational therapy, perhaps rehabilitative services if the patient is at a juncture where we can actually consider those. They're going to have to focus on skin care if patients are immobile because of the spinal cord compression. bowel and bladder management. Think about catheterization for bladder involvement. If patients are able to go home, nurses may be involved with self-catheterization or assisting patients in developing a bladder program at home. Same with bowel management, getting onto some type of bowel hygiene regimen so that they may go home. They also have to think about the side effects from steroids. If patients get more than the initial dose of steroids, if they're continued as part of the treatment, then think about things, or even just with the initial dose, think about such things as hyperglycemia. Nurses may be asked to manage that. They may need to manage mood disturbances and sleep disturbances. When we think about the impact that steroids have on other oncology patients, the exact same impacts happen on patients who are receiving steroids for malignant spinal cord compression. So that always needs to be in the mind of the nurse as he or she assesses the patient and does this ongoing evaluation of the interventions.
Jennifer, are there any age-specific care considerations for this patient population?
I don't really think of age-specific considerations for this population. I think more of comorbidity situations. So, for example, someone who has diabetes may already have peripheral neuropathies and may not recognize new peripheral neuropathies as something to be concerned about. Patients who already have mobility issues, perhaps related to age, perhaps related to other arthritic events or other orthopedic events that have occurred, may already have mobility issues and are not really thinking about that those are worsening, and therefore someone may need to be assessing them in the light of these new manifestations.
Jennifer, it has been a pleasure talking with you today, and just your expertise in this area is amazing, and hearing some of your patient experiences to help folks kind of put that into perspective of how it might be something that you would see in other side effect areas with a patient with cancer, and how we really just need to be in tune to our patients and letting them know how important it is to tell us when they're having issues. So as we're coming to the end of our podcast, I like to finish up with some questions that I ask every time, and I want to start those off with you now. And the first one is, what are some common misconceptions about malignant spinal cord compression?
One of the misconceptions is that it is not a very commonly occurring oncologic emergency. And I think that misconception comes from the fact that if you look at the overall oncologic population, it only occurs in about 5% of the general oncology population. We think of it as not very commonly occurring. Nurses may get some education on it as an initial overview in an orientation class, so to speak, but it's not really top of mind as far as oncologic emergencies that we need to be prepared about because of the low incidence in the oncology population in general.
Great. Next, what's something about malignant spinal cord compression that's not often discussed, but you wish people knew more about?
Well, I am feeding off my answer from the last question because this is the problem, right? It only occurs in 5% of the general oncology population. However, in certain select tumor types, we know that it is potentially very commonly occurring and that we have groups that are at high risk. And so I think nurses need to be very attuned to these groups. I've already mentioned solid tumors that are near the spinal cord that metastasize easily, such as breast, lung, renal cell, prostate. When nurses hear patients have those diagnoses, then that should be something that they refresh themselves on, that malignant spinal cord compression is an emergency that they refresh themselves on. Nurses who work with hematology patients need to also be aware that patients with multiple myeloma, 10 to 15% or even more of malignant spinal cord compression cases occur in patients with multiple myeloma. So it needs to be top of mind for nurses who are working with that population, as well as patients with Hodgkin's disease and non-Hodgkin's lymphoma.
What additional training or education do oncology nurses need to manage patients with malignant spinal cord compression?
Well, one of the things I would like to mention that we haven't really talked about is the impact of this emergency on patients and their caregivers. If the malignant spinal cord compression cannot be reversed, then you may have patients who are dealing with profound disabilities, the inability to walk, inability to urinate properly, the inability to have a bowel movement. They may be in a wheelchair. They may be completely paralyzed from, a certain area of the spinal cord down. And so one thing that nurses need to be aware of is the resources available to patients and family members who are now having to deal with this profound disability, on top of the knowledge that the patient's life may not be continuing for much longer. And so I do think that nurses need to educate themselves on the resources that are available to them and to the caregivers and patients, such as rehab facilities. They're going to need to have social work involved. They're going to need to have, as I mentioned, the rehabilitative services of physical therapy and occupational therapy. They may need to have hospice involved or the palliative care team involved with symptom management for these patients. There may need to be structural changes made to the patient's home, the things that I think we don't often think about. And it's not necessarily our job to think about all those things, but we just need to be aware of the impact that this emergency can have on patients and be prepared with some resources that we can then send them to. This can also include such things as caregiver support groups or psychological support for the patient and family. As I mentioned, this can potentially be a profound change for the patient and can, of course, have severe psychological effects such as depression and anxiety for patients who are already facing a very stressful situation.
And last, what are some additional resources for patients and providers who want to learn more about malignant spinal cord compression?
I think for oncology nurses, there are two very good resources that are published actually by the Oncology Nursing Society. And one is Marcel Kaplan's book on oncologic emergencies. It's excellent. I use it almost daily to remind myself of the details of all the oncologic emergencies. So I highly recommend it to oncology nurses. And then for the APPs, Dawn Camp-Sorrell has just published the 4th edition of the Clinical Manual for Oncology Advanced Practice Nurses. I'll have to be honest, I haven't read it yet, but I have used the 3rd edition many, many times. There are great chapters on identifying and managing oncologic emergencies. And so I am assuming that it would be even better and more detailed in the 4th edition. The other resources that members of ONS have at their fingertips is a huddle card about spinal cord compression. I think that's really nice to, again, help bring this not necessarily commonly occurring oncologic emergency to top of mind, as I keep using that expression. It's a nice summary of what spinal cord compression is and what nurses should be looking for, and is available on the ONS website. Unfortunately for patients, I did a search and it is difficult to find resources that are directed towards patients about spinal cord compression. The best that I could do was the American Cancer Society has a nice section on bony metastases and what that means and the risk factors involved with that. And there is a section on there on spinal cord compression. I do think the whole section on bone metastases is very useful for patients. But there is this nice little, it's not much, but there's a nice sort of clear description of spinal cord compression that they could read about. And then also the Leukemia and Lymphoma Society, They mention it as far as related to multiple myeloma, and that could be useful as well. But there isn't really any single resource that I could find that does a really good job of explaining in detail for patients what malignant spinal cord compression is about. So what that really means is that, again, it's so important that the nurse have a clear understanding of what it is, and using their oncology expertise really help describe for patients what they should be looking for and what actions they need to take if they start to have any of these signs and symptoms that we've been talking about.
Well, Jennifer, again, I just want to thank you for being with us today and for your information. I know that our listeners are going to see this as a valuable resource for them as a reminder or for new nurses coming into oncology. So thank you. Do you have any final comments for us today?
I hope through this talk that you get the feeling that I cannot emphasize enough how critical oncology nurses are in identifying these patients at risk, helping to educate patients about what they should be looking for. And then if these signs and symptoms are occurring in front of you or patients are calling you about them, recognizing the significance of these signs and symptoms, being able to implement evidence-based strategy once patients have been diagnosed, and really helping to support patients and families as they tackle and have to get through this potentially devastating oncologic emergency. Oncology nurses are crucial to this entire process, and I cannot emphasize enough how important you are and how proud I am to be an oncology nurse and what an impact you make on patients' lives in this particular oncologic emergency.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.